Margaret Chen is a 71-year-old retired school librarian from Columbus, Ohio. She has been taking lisinopril every single morning for 6 years. Her blood pressure numbers look great on paper. Her doctor is pleased, but Margaret is not doing well. She feels dizzy by noon and exhausted by 2 o'clock in the afternoon. She cannot make it through a chapter of the novel she is reading without nodding off. She tells her daughter, "I think I'm just getting old." Her daughter refuses to accept that. She insists on a second opinion. And when the new doctor reviews Margaret's chart, he does not change her diagnosis. He changes her medication. What he discovers shocks both of them. And what happens next is something every single person watching this needs to hear. I'm Dr. Alan Mandell, and whether you personally take amlodipine, losartan, or lisinopril, or you care for someone who does, this video has the potential to genuinely transform how you perceive your blood pressure therapy. Here is what I have come to firmly believe after years of dedicated practice working with older adults. These three drugs are undeniably life-saving. That is not up for debate. However, the manner in which they are prescribed, the dosages that are chosen, and the way patients are monitored, particularly in adults over the age of 65, is often dangerously incomplete. A vast number of side effects that older adults experience are routinely dismissed as mere consequences of the aging process, when, in actuality, they may very well be the medication speaking. Today, I am going to guide you through 6 critical, often overlooked pieces of information that most patients taking these medications have never been told. I need you to remain with me through all 6 points, because number 3 is a side effect that millions of people mistakenly blame on aging, when it is, in fact, directly caused by their medication. And number 5 involves a blood pressure reading that might look flawless on your chart, yet could actually be setting you up for a hospitalization. If you take any form of blood pressure medication, or if a family member does, I urge you to subscribe to this channel right now, because the insights we cover today could fundamentally alter the conversation you have at your very next doctor's appointment. Before we dive into the list, I want to provide you with a mental framework, a specific lens through which to view everything that follows. I refer to it as the dose assumption trap, and it operates in the following way. Pillar 1. Your doctor initially prescribed your medication based on established clinical guidelines. That is entirely appropriate and standard practice. However, what most people fail to realize is that these guidelines were largely constructed from studies that primarily involved individuals in their 50s and 60s. They were not designed for 78-year-olds who are concurrently taking 3 other medications and whose bodies process drugs in a vastly different manner than they did just 2 decades prior. Pillar 2. The very dose that successfully manages your blood pressure numbers on paper might quietly be generating symptoms that you are mistakenly attributing to old age. Fatigue, dizziness, brain fog, and swollen ankles are not inevitable, unavoidable parts of getting older. They may very well be medication side effects hiding in plain sight, simply waiting to be recognized. Pillar 3. Having a controlled blood pressure reading on your medical chart does not automatically equate to having optimal blood pressure for your unique body. A number that appears perfect in your records might, in reality, be making your daily existence considerably worse. That is the essence of the dose assumption trap. Your numbers look good, so everyone, including your doctor, assumes your medication is perfectly fine, and no one ever stops to ask you a simple, crucial question: how do you actually feel? Keep this framework firmly in your mind as we meticulously go through every single item on this list. Number 1. Understanding the 3 distinct medications, their 3 completely different mechanisms of action, and why it is absolutely critical to know which one you are taking. Consider the case of Robert Morales, a 68-year-old retired truck driver from San Antonio, Texas. During a routine physical examination, his blood pressure was found to be elevated. His doctor promptly handed him a prescription for amlodipine, accompanied by the simple instruction, "Take this once a day." Robert asked a single, straightforward question: "What does it actually do?" His doctor's reply was brief: "It lowers your blood pressure." And with that, the conversation ended. Robert took that pill every single day for 2 full years without ever understanding how it worked or why that particular medication had been selected for him. This fundamental lack of understanding nearly had severe consequences for him. Here is what Robert was never informed of, and what you, too, may not know. These three medications function through entirely different pathways within your body. Amlodipine is a calcium channel blocker. Its job is to relax the muscles found in the walls of your blood vessels, allowing them to widen. This dilation permits blood to flow through with less resistance, thereby reducing pressure. Losartan, on the other hand, is an angiotensin receptor blocker, commonly known as an ARB. It works by blocking a specific hormone that sends signals to your blood vessels, instructing them to constrict. Lisinopril is an ACE inhibitor. It prevents your body from producing the enzyme that is responsible for creating that same blood vessel constricting hormone. Why does this distinction matter so much? Because each of these different classes of medication carries its own unique set of potential side effects, drug interactions, and specific risks that become increasingly significant as we age. Knowing which medication you are taking is not trivial information, it is absolutely essential for your safety and well-being. So, here is your first actionable step. At your next appointment, ask your doctor this direct question: "Why did you choose this specific medication for me instead of one of the other available classes?" If you do not receive a clear, detailed, and specific answer that pertains to your personal health profile, then that is a conversation that is well worth continuing. And it is within these side effect profiles that things begin to get uncomfortable, particularly with one of these three medications. Number 2, understanding the side effect that your doctor might call normal, but which is anything but. Linda Hargrove is a 73-year-old former postal worker from Richmond, Virginia. She has been taking amlodipine for 4 years, and for the vast majority of that time, her ankles have been noticeably swollen. Not just a little puffy, but swollen to the extent that she could no longer fit into the shoes she had worn comfortably throughout her entire adult life. She brought this concern up to her doctor on at least 2 separate occasions. Both times, the response was essentially the same. "That is a very common side effect. It's harmless and nothing to worry about." Linda trusted that reassurance. She adapted to the situation. She purchased wider shoes. She made a point of elevating her feet every evening. She accepted this as her new reality, until one afternoon, when the swelling became so severe that her daughter insisted on taking her to urgent care. There they discovered that the edema had been masking a much deeper circulatory problem that had been silently developing without proper monitoring for over a year. This scenario is not rare. Research published in the Journal of the American Heart Association has documented that amlodipine-related peripheral edema affects up to 10% of patients, and the incidence rate increases significantly with advancing age and at higher dosages. In routine clinical practice, it is often trivialized and dismissed. However, the underlying physiological mechanism makes it far more than a mere cosmetic issue. Calcium channel blockers like amlodipine dilate the arteries, but they do not dilate the veins at the same rate. This imbalance causes fluid to leak from the capillaries into the surrounding tissue. In younger individuals, the body can often compensate for this change. But in older adults, who may already have reduced venous return and less efficient circulatory systems, this can create a cascade of further problems. Swelling leads to reduced mobility. Reduced mobility leads to further circulatory decline, and that decline leads to an increased risk of falls. That is not harmless by any measure. If you experience swollen ankles while taking blood pressure medication, do not simply accept it as an unavoidable nuisance. Request a comprehensive medication review. Alternatives do exist. Switching to an ARB, carefully adjusting the dosage, or combining lower doses of two different classes of medication can often effectively solve the problem. Never accept it's normal as the final, unquestionable answer when a side effect is actively altering the way you live your life. If you or someone you love has experienced swollen ankles from a blood pressure medication, I want you to type the word swelling in the comments section right now. I genuinely want to hear about your experience. However, amlodipine is not the only medication harboring hidden side effects. If you are taking lisinopril, what comes next may sound painfully familiar. Number 3, the persistent cough that simply will not go away and what it is really trying to tell you. James Whitfield is a 69-year-old retired electrician from Knoxville, Tennessee. 3 months after starting lisinopril, James developed a dry, hacking, persistent cough. It was not a cold, it was not seasonal allergies. It was just a constant tickle in the back of his throat that gradually intensified into a cough that refused to subside no matter what he tried. He visited a pulmonologist. He underwent a chest X-ray. On some nights, he even lay awake worrying that he might have lung cancer. For 8 long months, not a single doctor he consulted ever asked him one simple, obvious question: what medications are you currently taking? This is not an uncommon side effect. A CE inhibitor-induced cough affects up to 15% of patients, and some population studies suggest that the actual number may be even higher. The New England Journal of Medicine has extensively reviewed the mechanism behind this phenomenon. Lisinopril works by blocking the enzyme responsible for breaking down a substance called bradykinin. When bradykinin accumulates in the lungs, it irritates the airways and triggers a persistent dry cough that no amount of over-the-counter cough medicine will effectively relieve. In older adults, this cough is far more than a minor annoyance. It disrupts sleep patterns. It can cause dizziness and lightheadedness during severe coughing episodes. It increases the risk of falls, and it diminishes overall quality of life in ways that are difficult to quantify, yet impossible to ignore. If you develop a new, unexplained cough after starting an ACE inhibitor, such as lisinopril, inform your doctor immediately. Switching to an ARB, such as Losartan, eliminates this problem in the vast majority of patients. This is a well-known, thoroughly documented, and completely manageable issue. It is not something you should ever be told to simply tolerate and live with. Now, after hearing all of that, Losartan might sound like the safer, more appealing option. However, number 4 reveals a hidden danger that patients taking Losartan specifically need to understand clearly. Number 4, the silent potassium problem that no one is adequately monitoring. I am not going to share a single patient story for this one because the data from hospitals tells a story that is far more concerning and widespread than any individual case. Both ARBs, such as Losartan, and ACE inhibitors, such as lisinopril, have a well-documented effect that receives far too little attention during routine medical care. They can significantly increase potassium levels in the blood. The medical term for this condition is hyperkalemia. Data published in the American Journal of Kidney Diseases shows that hospitalizations related to hyperkalemia among older adults taking these classes of medications are alarmingly common and, concerningly, continue to rise. Here's the physiological process of how it happens. These medications reduce the activity of a hormone called aldosterone. Aldosterone normally sends signals to the kidneys, instructing them to eliminate excess potassium from the body. Less aldosterone activity means that less potassium leaves the body. Now consider the stark realities of aging. Kidney function naturally declines as we grow older, meaning that the kidneys become less efficient at removing potassium from the bloodstream. Then consider what many older adults are encouraged to eat: bananas, spinach, potatoes, sweet potatoes, and beans, all widely promoted as heart-healthy foods and all extremely rich in potassium. Next, add potassium-containing supplements or salt substitutes, which many health-conscious adults use without giving them a second thought. The slow accumulation of potassium in the blood can eventually become dangerously high, and here is the part that scares me the most. Hyperkalemia often presents with absolutely no symptoms at all until it triggers a cardiac arrhythmia, a potentially fatal heart rhythm disturbance that can strike with no warning whatsoever. What should you do instead? If you are on Losartan, Lisinopril, or any medication in the ARB or ACE inhibitor class, you need your potassium levels and kidney function checked regularly at an absolute minimum, every 6 months. This is not optional. It is essential, potentially life-saving monitoring that far too many patients are simply not receiving. At your next appointment, ask this one critical question: when was my potassium level last checked? If no one in the office can give you a clear, definitive answer, that is a significant problem that needs to be addressed immediately. If you have been on one of these medications for more than a year and have never had your potassium levels tested, I want you to type the word "never" in the comments. I think you will be surprised to see just how many of us are in the exact same situation. But here is the one that scares me the most as a physician, and it is the one that almost no one is talking about openly and honestly. Number 5. The blood pressure number that is actually too low, the point at which your medication becomes the danger. Dorothy Flanagan is 76 years old, a retired teacher's aide from Scranton, Pennsylvania. Her blood pressure was what her doctor proudly called perfectly controlled, reading 118/70. At every visit, her doctor would smile warmly and say, "Your numbers look great, Dorothy." And Dorothy would smile back, relieved. But Dorothy was falling. She fell twice in her kitchen and once in her driveway, where she scraped both palms badly on the rough concrete while desperately trying to catch herself. Then, one Tuesday morning, her daughter found her on the bathroom floor. She had stood up, the room went completely black, and she went down hard. The emergency room diagnosis was orthostatic hypotension. Her blood pressure was plummeting dangerously every single time she attempted to stand up. The very medication that was supposed to be protecting her heart was putting her bones and her brain directly at risk. The data on this phenomenon is compelling and continues to grow. Follow-up analysis of the landmark SPRINT trial, along with a widely cited 2023 study published in JAMA Internal Medicine, found that intensive blood pressure lowering in adults over 75, specifically pushing systolic pressure below 120, was associated with significantly increased rates of falls, fainting episodes, acute kidney injury, and dangerous electrolyte imbalances. In response, the American Academy of Family Physicians has recommended more relaxed blood pressure targets for adults over 75, suggesting that a systolic pressure below 150 may be more appropriate for many patients with multiple health conditions. Let me walk you through the cascade of events, because this is the one I need you to truly understand. Medication lowers blood pressure too aggressively. You stand up from a chair or get out of bed. Blood pools in your legs because your blood vessels cannot constrict fast enough to compensate for the change in position. Your brain receives insufficient blood flow. You feel dizzy, your vision dims, you reach out for something to steady yourself. You miss, you fall, you fracture a hip. Surgery inevitably follows. Then a hospital stay where hospital-acquired infections are a common threat. Then prolonged immobility. Then muscle loss, cognitive decline, and depression. One single, perfectly controlled number on a chart can trigger this entire devastating chain of events. And it all starts with a blood pressure reading that everyone in the room mistakenly thought was good news. Here is what you need to do. Ask your doctor to check your standing blood pressure, not just your seated blood pressure. Request orthostatic vitals at every single visit, and have an honest, open conversation about whether your current blood pressure target is genuinely appropriate for your age, your history of falls, and your overall health status, because a systolic reading of 140 might be genuinely safer for you than 118. The best number is not always the lowest number. This brings us to the conversation that ties all of this together, and the one practical tool I want you to walk away from this video holding firmly in your hand. Number 6. The blood pressure medication checkup. 5 essential questions to bring with you to your next appointment. I want you to screenshot this list, write it down on a piece of paper, or print it out and bring it with you. These 5 questions have the power to change the way your blood pressure is managed. Question 1. Why am I on this specific medication and not another class? You deserve to know why amlodipine was chosen over losartan, or why lisinopril was chosen over an ARB. The answer you receive should be specific to your personal health circumstances, not a generic one-size-fits-all response. Question 2. What is my blood pressure when I am standing, not just when I am sitting? A reading taken only while seated gives you only half the picture. The other half could save you from a debilitating fall. Question 3. When were my potassium and kidney function last tested? If you are on an ACE inhibitor or ARB and no one is regularly monitoring these vital numbers, that is a significant gap in your care that needs to be closed immediately. Question 4. Is my current blood pressure target appropriate for my age and overall health? The right target for a robust 55-year-old is not automatically the right target for a 78-year-old with other health conditions. This question opens a conversation that many doctors do not initiate themselves, but they will respect you for starting it. Question 5. Are any of my other medications or supplements interacting with this one? Blood pressure medications do not exist in a vacuum. NSAIDs, certain antidepressants, potassium supplements, and even some over-the-counter cold medications can interfere with or dangerously amplify the effects of what you are taking. Any physician who takes your health seriously will not only welcome these questions, they will respect you more for asking them. And if your doctor dismisses you or becomes defensive when you raise these legitimate concerns, that tells you something incredibly important about whether that doctor-patient relationship is truly serving your best health interests. Let me come back to Margaret Chen, the woman from our opening who genuinely believed she was simply succumbing to old age. Her new doctor did not alter her underlying diagnosis. Instead, he lowered her dose and switched her to a different medication class. Within just 3 weeks, the dizziness completely stopped, and the overwhelming fatigue lifted. She told her daughter, with tears in her eyes, "I feel like I just got 2 years of my life back." Margaret's blood pressure is still very well controlled, but now, for the first time in years, the number on the chart and the life she is actually living finally match. Here is what I want you to carry with you long after this video ends. A blood pressure pill should help you live better, not just live longer on paper. If your medication is successfully controlling a number on a chart, but is quietly stealing your energy, your balance, your mental clarity, and your confidence, that is not effective treatment. That is a trade-off you never agreed to, and you have every right to question it. The best blood pressure for you is not always the lowest one. It is the one that lets you live your life fully. If you are currently on any blood pressure medication, I genuinely want to hear your story. What are you taking? And has any healthcare professional ever sat down with you and asked whether it is still the right fit for you? Please tell me in the comments below. Your personal experience could be the very thing that helps someone watching this video right now, someone who is going through the exact same struggles. And if this video made you think differently about your treatment, please share it with someone you love. Make sure to subscribe to this channel so you do not miss what is coming next. I'm Dr. Alan Mandell, and I will see you in the next one.